Thank you for that introduction. My name is Dr. Sharon Beth Larson, and I'm a cardiac surgeon at the University of Iowa. It is my honor to present surgery for aortic stenosis. I have no disclosures, and our objectives will cover the recommendations for aortic valve replacement in multiple patient groups. Recommendations are based on the multiple stages of valvular aortic stenosis, and those are based on valve anatomy, hemodynamics, consequences of valve obstruction on the left ventricle and vasculature, and symptoms. It is a complex staging system. Class C includes asymptomatic severe aortic stenosis patients, those with normal and reduced ejection fraction. Stage D includes patients with symptomatic severe aortic stenosis with a classic triad of symptoms of exertional dyspnea, exertional angina, and exertional syncope. Stage D2 patients have symptomatic severe low-flow, low-gradient aortic stenosis with reduced ejection fraction. And stage D3 patients are symptomatic with severe low-gradient aortic stenosis with normal ejection fraction or paradoxical low-flow severe aortic stenosis. We know that surgery for aortic stenosis is recommended based on the natural history of patients with unoperated aortic stenosis. In these patients, the prognosis is poor, especially in those patients exhibiting the characteristics of severe aortic stenosis. Recommendations include conditions under which aortic valve replacement is recommended, is indicated, is considered reasonable, and should be considered. Aortic valve replacement is recommended in symptomatic patients with severe aortic stenosis. We know that survival during the asymptomatic phase is similar to age-matched controls, with a low risk of sudden death. And the rate of symptom onset is strongly dependent on the severity of aortic stenosis. Once even mild symptoms caused by severe aortic stenosis are present, outcomes are extremely poor unless the outflow obstruction is relieved through aortic valve replacement. And for severe asymptomatic and calcific aortic stenosis, the only effective treatment is aortic valve replacement. Aortic valve replacement is recommended for asymptomatic patients with severe aortic stenosis and an ejection fraction of less than 50%. In patients with a low ejection fraction and severe aortic stenosis, survival is better in those who undergo aortic valve replacement. Depressed ejection fraction is caused by excessive afterload. So left ventricular function improves after aortic valve replacement, and there is reduced afterload, which results in survival improvement. Aortic valve replacement is indicated for patients with severe aortic stenosis when undergoing cardiac surgery for other indications. The evaluation for patients undergoing valve surgery will include coronary angiography and will often uncover coronary artery disease. Disease progression occurs in nearly all patients with severe asymptomatic aortic stenosis. Symptom onset within 2 to 5 years is likely when the aortic velocity is greater than 4 meters per second or the mean pressure gradient is greater than 40 millimeters of mercury. So the additive risk of aortic valve replacement at the time of other cardiac surgery is less than the risk of reoperation within 5 years. Aortic valve replacement for asymptomatic patients with very severe aortic stenosis is reasonable. In patients with very severe aortic stenosis and an aortic velocity of greater than 5 meters per second or mean pressure gradient greater than 60 millimeters of mercury, the rate of symptom onset is approximately 50% at 2 years. There are higher rates of symptom onset and major adverse cardiac events in patients with very severe aortic stenosis. Early surgery versus surgery at symptom onset leads to lower all-cause mortality risk. So it's reasonable to consider an elective aortic valve replacement in patients with very severe asymptomatic aortic stenosis if the surgical risk is low rather than waiting for symptom onset. Aortic valve replacement is reasonable in apparently asymptomatic patients with severe aortic stenosis with an exercise test demonstrating decreased exercise tolerance or a fall in systolic blood pressure. Exercise testing may be helpful then in clarifying symptom status in patients with severe aortic stenosis. For patients whose symptoms are provoked by exercise testing, they are then considered symptomatic, and the recommendation would be to undergo aortic valve replacement. For patients without overt symptoms who have a decrease in systolic blood pressure below baseline or a failure of blood pressure to increase by at least 20 millimeters of mercury, and a significant decrease in exercise tolerance compared with age and gender normal standards, the symptom onset within 1 to 2 years is 60 to 80%. So it's reasonable to consider elective aortic valve replacement in these patients when surgical risk is low. Aortic valve replacement is reasonable in symptomatic patients with low flow, low gradient severe aortic stenosis with reduced ejection fraction. The mean pressure gradient is a strong predictor of outcome after aortic valve replacement, and there are better outcomes with higher gradients. Outcomes are poor with severe low gradient aortic stenosis, but outcomes are still improved with aortic valve replacement compared with medical therapy in those with a low ejection fraction. Ejection fraction typically increases and may return to normal if afterload mismatch was the cause of left ventricular systolic dysfunction. Aortic valve replacement is reasonable in symptomatic patients with low flow, low gradient severe aortic stenosis with an ejection fraction of 50% or greater if clinical hemodynamic and anatomic data support valve obstruction as the most likely cause of symptoms and the patient is normotensive. In low flow, low gradient severe aortic stenosis with preserved ejection fraction, it occurs in 5 to 25% of patients with severe aortic stenosis. Asymptomatic patients have a poor prognosis and might benefit from aortic valve replacement. Outcomes are worse in symptomatic patients with low flow, low gradient aortic stenosis with a normal ejection fraction compared with patients with high gradient severe aortic stenosis. So survival may be improved with aortic valve replacement versus medical management in the symptomatic patient with low flow severe aortic stenosis. Aortic valve replacement is also reasonable for patients with moderate aortic stenosis who are undergoing cardiac surgery for other indications. We know that calcific aortic stenosis is a progressive disease, and it is reasonable to perform aortic valve replacement at the time of other cardiac surgery when moderate aortic stenosis is present, when the risk of progressive valvular heart disease is balanced against the risk of repeat surgery within 5 years. Aortic valve replacement may be considered for asymptomatic patients with severe aortic stenosis if the patient is at low surgical risk and serial testing shows an increase in aortic velocity of 0.3 meters per second or greater per year. The predictors of rapid disease progression include older age, more severe valve calcification, and a faster rate of hemodynamic progression on serial studies. So in patients with severe aortic stenosis and predictors of rapid disease progression, elective aortic valve replacement may be considered if the surgical risk is low. Surgical aortic valve replacement is recommended for symptomatic patients with severe aortic stenosis and asymptomatic patients with severe aortic stenosis who meet an indication for aortic valve replacement when the surgical risk is low or intermediate. The choice of surgical aortic valve replacement is based on surgical risk, patient frailty, comorbid conditions, and patient preferences and values. Surgical aortic valve replacement offers a survival benefit, improvement in symptoms, and improvement in left ventricular systolic function in patients with severe symptomatic aortic stenosis. Outcomes after aortic valve replacement are excellent in patients who do not have a high procedural risk. Surgical aortic valve replacement should be considered over transcatheter aortic valve replacement in patients who are at higher surgical risk but have severe multivessel coronary disease, because concomitant severe multivessel coronary disease is best served by surgical aortic valve replacement and coronary artery bypass graft surgery. In summary, our indications for aortic valve replacement and aortic stenosis include the symptoms, severity of aortic stenosis, the ejection fraction, and whether or not other cardiac surgery is indicated. And recommendations for surgical valve replacement for aortic stenosis are based upon comparisons of the natural history of patients with aortic stenosis to outcomes after surgical aortic valve replacement. Thank you.